Bajé estos dos.
Okay.
¿Cuál es el logo de
Be good.
Este. Y este.
I think we're sharing the wrong screen. Oh, it might be sharing.
No, esto es como que ya no sé qué es esta, mira.
Whole screen. If you stop.
Bajé este.
Okay. And then,
¿Qué pasa, María?
let's see.
Mira,
Oh, there we go.
bajé estos dos para que no pase lo mismo.
Okay, cool.
Ok,
And I emailed my number in case you need anything. Yeah, feel free to text anytime.
Awesome.
Thank you.
Thanks. Parece como yo lo tengo.
Okay, can you guys hear me okay?
Yo lo tengo.
Yeah, volume's decent, okay. And on Zoom, I'm hoping you can hear too. If not, somebody say something. So I'm Kelly. I am a oncology pharmacist at Johns Hopkins. I work in the ambulatory space, so I work in one of the clinics in the cancer center. I work specifically with genitourinary malignancies, so that covers testicular, prostate, bladder, kidney cancer. But I do have PGY2 training in oncology, so I got to see a little bit of everything during my training. And today we're going to be talking about topoisomerase inhibitors and antimicrotubule agents. And I believe this is right on the heels of your kind of science portion of these agents yesterday. So hopefully this will just build on that, potentially a little bit of overlap and reinforcement of some of the important things. And I don't know how to get that away, but I think hopefully it'll be okay. Okay, that's better. All right, so our goals today are for you to be able to describe the main clinical uses of topoisomerase inhibitors and antimicrotubule agents, explain the main adverse effects and management for those adverse effects, and identify some strategies to prevent and treat toxicities, specifically associated with anthracycline administration. So we'll start with topoisomerase inhibitors. Topoisomerase inhibitors are enzymes that are playing an important role in DNA replication and transcription within the cell by controlling the twisting, interlinking of DNA molecules. Topoisomerase essentially makes a small cut in the DNA at places that have too much tension and then repairs that cut during the DNA replication. This helps prevent tangling, supercoiling during DNA replication. And there are two different types of topoisomerase enzymes, so topoisomerase 1 and 2. Type 1 makes single-stranded cuts in DNA, allowing relaxation, and then that cut is repaired. Type 2 cuts both strands of the DNA, passes through an unbroken double-stranded DNA through it, and then repairs the cut strands. So these topoisomerase enzymes are a target for cancer therapies because disruption of this process prevents DNA from unwinding, which then results in DNA breaks caused by too much tension within the DNA coil, and an accumulation of those DNA breaks ultimately then stops replication and kills the cells. So our first topoisomerase inhibitor to talk about is irinotecan. Irinotecan is a topoisomerase 1 inhibitor. So this class is also referred to as camptothecans, owing to its origins from a Chinese tree, Camptotheca. The main uses for irinotecan are in GI malignancies, like colorectal, pancreatic, esophageal, or gastric cancer, as well as cervical cancer and lung cancer. You can see a couple of the example regimens listed at the bottom of this table for GI cancers. So FOLFIRI, FOLFIRINOX, In these regimens, irinotecan is given in combination with fluorouracil and oxaliplatin. The Erie part of the name of these regimens is the irinotecan. Pretty much every chemotherapy agent we're going to talk about today is administered intravenously unless otherwise specified, and irinotecan is no different there. The two major toxicities that are associated with irinotecan are diarrhea and myelosuppression. Both of those are a black box warning on irinotecan. I want to talk a little bit more about diarrhea management because this is somewhat unique toxicity of irinotecan and can be quite severe if not managed appropriately. So there's both an acute and a delayed presentation of diarrhea with irinotecan. Acute diarrhea occurs within 24 hours and is really a cholinergic reaction that's resulting in diarrhea or abdominal cramping and discomfort. Acute diarrhea or this cholinergic reaction can be treated or even prevented potentially with atropine. Delayed diarrhea is then occurring greater than 24 hours after administration of irinotecan and is more what we are generally seeing with chemo-induced diarrhea from other agents that's due to mucosal damage of the GI tract and can be managed by with loperamide. Other non-pharm changes like hydration, avoiding dietary triggers that can worsen diarrhea. Those are all still valuable supportive care for diarrhea caused by irinotecan as well, but atropine and loperamide have a really big role in managing and preventing severe complications from diarrhea with irinotecan. Irinotecan has recommended dose adjustments for renal and hepatic dysfunction, as well as in patients with UGT1A1 polymorphism, which can result in exposure to increased amounts of the active metabolite of irinotecan. So just some places to pay attention and be cautious of dose adjustments with irinotecan. Then moving on to topoisomerase 2 inhibitors, we have etoposide, which is a semi-synthetic derivative of the extract from mayapple root. So you'll notice a theme a little bit with these agents today. A lot of them are derived from plant species. Etoposide is a non-intercalating agent, meaning it binds to DNA without inserting itself between DNA base pairs, in contrast to intercalating agents like the anthracyclines, which we'll talk about next, that are intercalating agents. They essentially slide between the DNA base pairs, disrupt that DNA sequence. There are a variety of uses for etoposide, including lung cancer, testicular cancer, ovarian cancer, lymphomas. Really, all of these agents today have a pretty wide application between solid tumors and hematologic malignancies, and are generally going to be used in combination with something else. So you'll see again at the bottom of this slide a couple example regimens. So there's a combination regimen for lymphoma, and then we also use etoposide a lot in lung cancer and in combination with carboplatin and in other disease states as well. The primary toxicity with etoposide is myelosuppression. So that is a major kind of monitoring and dose limiting toxicity for etoposide. We can also see hypotension during the infusion of etoposide. This can be mitigated by slowing the infusion rate and using appropriate concentration of the solution. So targeting a specific concentration can also help decrease hypotension. Nausea, vomiting, diarrhea, mucositis, and alopecia are also toxicities that we can see with etoposide too. Etoposide does have an oral formulation. Generally, we're using the IV formulation, but there is sometimes a use for oral etoposide, and it's about 50% bioavailable. So dosing of oral etoposide is essentially going to be double our standard dosing for IV therapies. Next, we have the anthracyclines, which include doxorubicin, daunorubicin, idarubicin, epirubicin, valrubicin. So rubicin is a trigger to you that this is an anthracycline. Mitoxantrone is the kind of odd man out here. It's slightly different, but still kind of lumped in this anthracycline class. It's an anthracenodone, so very related, slightly different a little bit. As you can see in these images here, most of these agents are red or orange in color, with the exception of mitoxantrone, which is blue. So these are pretty recognizable agents in the pharmacy as well when being prepared, given their kind of vibrant color. So anthracyclines are also topoisomerase 2 inhibitors. As I mentioned, these are intercalating agents, meaning they are inserting themselves at points of uncoiling in the double helix to inhibit topoisomerase 2 activity. These agents also have many indications and uses. Some of the key examples are in leukemias, lymphoma, multiple myeloma. So kind of across the board with our heme malignancies, and then a lot of uses within solid tumors as well, sarcoma, lung, breast, gynecologic malignancies. Mitoxantrone only has one indication in prostate cancer, and I will tell you, as someone who works in prostate cancer, we very rarely use mitoxantrone anymore, but that is kind of its one therapeutic use. There are some of the example regimens listed here at the bottom of the slide again for you guys. So a lot of these chemo agents are being used in combination with other chemotherapeutics as well. So that's the case for the anthracyclines as well. We have an example regimen of doxorubicin and cyclophosphamide for breast cancer. In sarcoma, one of the more common regimens includes mesna and ifosfamide. And then R-CHOP is a really commonly used regimen for lymphoma, including rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Dose adjustments are recommended in hepatic and renal dysfunction for anthracyclines, and they're generally not recommended in patients with severe hepatic impairment. From a toxicity standpoint, there can be quite a few. Two of the big ones that I want to talk more about today are cardiotoxicity and extravasation, but I also want to mention the others. So those can include alopecia, mucositis, nausea, vomiting, pretty significant myelosuppression here as well. Additionally, kind of going back to their vibrant color, as I mentioned, these agents can cause temporary discoloration of body fluids. So that's kind of a nice counseling point for patients to be aware of if they're starting therapy with these, since that's something that they may notice. It's temporary, it resolves after kind of the chemo has been cleared out of their body, but could be a little bit alarming to patients. Yeah.
Question.
Mhm.
So, like the patient is wearing like heart failure or has like a heart pathology, usually avoid using this medication.
Yeah, so thank you for this transition into the next couple of slides. We're going to talk a lot more about cardiotoxicity and kind of how we approach that in patients on anthracyclines. Okay, perfect. That actually is like perfect transition. I was done with that slide. Okay, so taking a closer look at the anthracycline-related cardiotoxicity, which is a major toxicity of concern with these agents. Anthracycline cardiotoxicity is caused by a combination of mechanisms. So oxidative stress, DNA damage, resulting in then cell death that affects not only the cancer cells, but also cardiac cells. So we've talked about anthracyclines are targeting topoisomerase 2, and topoisomerase 2 alpha is the active enzyme in cancer cells. In cardiomyocytes, we see topoisomerase 2 beta, which the anthracycline can also inhibit, causing those same DNA strand breaks and cell death damage in those cardiomyocytes too. So there are two different types of cardiotoxicity with anthracyclines, acute and delayed. Acute cardiotoxicity presents it can present immediately, so even like during infusion, or within days of treatment. It's much less common. It's generally transient and reversible. It might be asymptomatic, or it can present with tachycardia, hypotension, arrhythmias like atrial fibrillation, pericarditis or myocarditis. Very rarely can lead to heart failure or myocardial infarction, but generally, acute cardiotoxicity from the anthracyclines is reversible. Sometimes slowing the infusion rate is a way to decrease symptoms of acute cardiotoxicity. Chronic cardiotoxicity develops over months or years and is more common and unfortunately generally considered irreversible. So this is what we're thinking about when we're talking about anthracycline-induced cardiomyopathy and heart failure. Chronic cardiotoxicity onset is often delayed, and it's very important to understand that this is a dose-dependent toxicity. So because of that, lifetime cumulative dose is tracked for patients who are receiving anthracyclines, and a lifetime cumulative doxorubicin dose approaching 400 or greater milligrams per meter squared significantly increases risk of cardiotoxicity. So on the image here on the left, you can see our 400 kind of cutoff there is where we're really starting to see that risk of heart failure increasing pretty quickly. And by the time there's a couple different models that have looked pretty closely at this. By the time if you're at 400, your risks are 3 to 5% increased. By the time you reach 550 milligrams per meter squared, depending on the model, we're looking at closer to 7% to up to 26% increased risk. So pretty quick jump there. Yeah.
Still lifetime cumulative dose. Is the amount you give into the patient, or what is left in the patient after expression?
Yeah, that's a good question. So the question was, what does lifetime cumulative dose mean? Is that like total doses ever, or is that kind of a what's accumulated in their body? So this is ever doses. So like a patient with a leukemia patient, a young leukemia patient who receives a regimen with an anthracycline in it. That is then like for the rest of their life goes towards their cumulative dose. So if they received like 200, actually, let me just go to the next slide because this is a good visual for this. So this is a tool we have in our electronic medical record that tracks doses. So this is a patient who received doxorubicin. This is they've received 93.5 milligrams per meter squared total so far. If they're not on this therapy anymore, if they were to start another therapy with an anthracycline in it later on, we're going to start from this same spot. So it's ever exposure to an anthracycline goes towards that cumulative dose. So really, they hopefully shouldn't have a bunch accumulated in their body at any time if we're dosing it appropriately, right? But this is exposure. So a cumulative exposure maybe is a better way to think about it. Any doses of anthracyclines are going to add up to this. And then kind of looking here, so we have on our chart in the record, we have this anthracycline family of drug line. So if this patient then went on to receive idarubicin, that's going to add into that total like family line. So it doesn't have to be the same one. They all carry the risk. So if you're exposed to 3 different ones, they're all adding up to kind of that cumulative dose. There are some conversions that are done between the different drugs to get to a base of like, doxorubicin is really what we use as kind of our base to calculate the cumulative dose off. Yeah.
So if a patient, for example, received doxorubicin 20 years ago, and like for some unfortunate reason, or 15 years, 10 years ago, for some unfortunate reason, the cancer goes back. And he's in another institution. Does like you need to counsel the patient to know that there's like a baseline of of how many of a dose that they need to have, or like how does that work?
Yeah, that's a really good question and a really good point on like transitions of care and making sure that everyone understands the risk so the right information is shared, right? So absolutely, if when patients receive anthracyclines, they should be counseled pretty extensively on like this is a risk and you carry this risk with you now. And so patients are given, and I mean, over decades, like things can get lost, right? But patients, especially like pediatric patients that receive anthracyclines, are given very clear documentation of like this is the anthracycline amount that you have received during your treatment. And it's like, I don't know, I kind of think about it like a medical alert bracelet almost, that it's something that then if they went and saw like another oncologist, that should be a very clear part of their record, that like it's very well known that they have this risk and they have this anthracycline exposure because of that pretty quick uptick in risk once you get to this threshold of about 400. Yeah. So the drug is not necessarily in the body. It's that the drug has already possibly done damage. And so yes, the drug should absolutely be cleared from the body at some point, right? But we know that like the repeated exposure, and it's like I said, it's not reversible. The damage that's done is not necessarily reversible. So we kind of consider like that you're at this point. You could probably very, 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 very cautiously go above that kind of maximum threshold if you really needed to. But that would be a pretty important risk benefit discussion with the patient. And like looking at, are there other options that might be better than kind of increasing that risk, and knowing how quickly the increase of heart failure can happen. Great questions. Okay. Keep asking the questions. I love it. It's great. So other risk factors for cardiotoxicity from anthracyclines are kind of risk factors for cardiotoxicity just in general. So existing heart disease, hypertension, dyslipidemia, diabetes, renal failure, smoking, age, advanced age or young age, and obesity increase risk of cardiotoxicity with anthracyclines. There are other therapies for cancers that carry their own cardiotoxicity risk. So there are some of the anti-HER2 therapies that we use very commonly in breast cancer, where we're also using anthracyclines pretty commonly. So there's a cumulative risk of cardiotoxicity with both of those agents, or radiation to the chest as well can also increase risk of cardiotoxicity. So important to recognize that there are some other risk factors for cardiotoxicity that are important to be mindful of as well. Patients should always have a baseline EKG and echocardiogram before they're starting on anthracycline. This should be repeated periodically throughout treatment as well. A lot of times we use kind of a general threshold of about a 50% left ventricular ejection fraction. That can vary depending on the patient, but when we're getting to that decreased ejection fraction, I'm really being cautious about giving an anthracycline. Dexrazoxane, which we'll talk about a little bit more in a couple slides, can be used as a chemoprotectant in really high-risk patients who are receiving high-dose anthracyclines. And this is kind of dexrazoxane carries its own risks, but can be an option for trying to reduce the risk of cardiotoxicity as well. The other toxicity to talk about with anthracyclines is extravasation. So extravasation is a severe tissue injury and necrosis. This can be very significant. So it's important to take measures to prevent and then also understand how to manage extravasation. So extravasation can be prevented or tried to minimize by administering via IV only. So would not want to give an anthracycline intramuscular or subcutaneous. The risk of extravasation would be significantly increased in those cases. And then if we can infuse via a central line versus a peripheral line, that's the preference as well. If we have to use a peripheral line, we should be checking very, very closely and frequently during the infusion for blood return, making sure that there hasn't been any compromise to this tissue in that area. Yeah. This is an anthracycline. I think that this one, I think those doxorubicin, but they all carry the same extravasation risk.
Because of the medication? Or-
Yeah. So it's honestly, it's very similar to how it can cause toxicity in like cardiomyocytes. We have that same, it's a direct toxicity from the medication. So the same way it's killing cancer cells, it's like it spreading quickly and exposing all of those cells like right in the area that it's being infused. The skin cells, when it's like leaking out from the blood vessel. Does that make sense? Kind of.
So when we have done the mind thing, well, that means this is probably what it's also doing inside the body. In terms of what is going to the arteries, the veins.
Yeah, so
It's actually happening
yeah.
inside the body. It happens outside of the cancer cells.
Yeah, that's a good question. So are we expecting that this is like what the inside of their body looks like too? This is more because this is in like small capillaries that don't have the ability to like retain the drug and like spread it through. I mean, so maybe if we think a little bit about like how we manage this will help because it's a leaking from the capillaries that causes this. So that's why like administering via a central line keeps it in the bloodstream in those like veins and arteries that can handle it and get it to where it needs to go. And it does get spread throughout the body. So it's going to all the cells, right? But not at such high concentrations. So when it's being administered through a vein or on their hand, and it's leaking kind of in high concentrations to those capillaries and those tissues, the cells, like right there. That's where you get this toxicity from the really high concentrations and that exposure like acutely. If we're getting it into the bloodstream, it's more diluted. And then your body has a more ability to kind of avoid this like really severe toxicity kind of in those localized areas. So to manage it, you want to stop it. You want to stop adding more drug that is directly causing this damage. Cold compresses, so like applying ice to the area is really important too, to kind of help like constrict those blood vessels, stop the like spread of the drug into that localized area. And then dexrazoxane, again, here is another use for this kind of antidote to anthracyclines. Because what we understand about dexrazoxane is that it is binding that topoisomerase 2 beta. So that's what I mentioned with the cardiotoxicity. That's the enzyme that results in a lot of these kind of undesired toxicities, like the cardiotoxicity and then the extravasation injury. So if we can prevent it from being able to bind and then the cell death to occur quickly from that high concentration of the drug in that area, we can stop the spread of extravasation. So we can administer dexrazoxane after an extravasation injury to then help treat and stop that from spreading. If extravasation is really severe or is not caught early or identified early, which is why it's important, like I mentioned, if we're giving this through a peripheral line, that the nurse that's administering it is like very, very, very diligent about checking that infusion site repeatedly. We can, stop it early, treat it, prevent it from spreading. If it's really severe, then sometimes surgical debridement of that necrotic site is required as well. There is different dosing and different kind of recommendations for prevention of cardiotoxicity or treatment of extravasation with dexrazoxane, but we do understand that it's the same mechanism that's really preventing the damage in both instances. So it's that binding of the topoisomerase 2B enzyme or 2 beta enzyme that then stops like the damage to the cardiomyocytes and the damage to like epithelial cells in the area of the extravasation as well. So it's preventing the anthracycline from being able to bind to the topoisomerase 2 in that area. And prevent the damage, the cell death as a result of that topoisomerase 2 inhibition. Specifically is binding the 2 beta and not 2 alpha, which is where our drugs are binding. So we still have, or where it's binding in like a cancer cell to exert its activity. So we can still see efficacy and it still can be effective in patients who receive dexrazoxane, but we can prevent some of these major toxicities by giving dexrazoxane or treat by giving dexrazoxane.
If severe, it requires surgery.
Mhm.
What's the goal of surgery? Is it to just drain or what are they doing?
To remove like necrotic tissue. Mhm. Yeah. So someone who, if it was severe and someone needed surgery, they should have also gotten dexrazoxane to treat and to stop the extravasation as well. But if damage has been done and has been really severe, then they might have to surgically debride and remove some of the dead tissue as well so that it can start to heal and kind of recover. When we're giving for prevention of cardiotoxicity, it's being given like in addition to therapy. So you're giving the chemotherapy and you're giving dexrazoxane as well. It's administered in a ratio kind of the dose of the anthracycline to dexrazoxane to prevent cardiotoxicity for treatment of extravasation. It's a fixed flat dose. It's given IV. And it's given for 3 days. You really want to start dexrazoxane like as soon as possible after someone has an extravasation to kind of help the spread of the extravasation. Okay, so dexrazoxane, super important antidote or supportive care piece for anthracyclines to be either for prevention or for treatment. Okay. Well, I had some pull everywhere for you guys, but it doesn't look like it's gonna work. So that's okay. We'll just go through the slides and you can raise your hands or just shout out what you think the correct answer is. Since it doesn't seem like the pull thing is gonna work. So which of the following is not a topoisomerase 2 inhibitor? Yeah, yep, irinotecan. So what class is irinotecan or what's the mechanism? Yep. Perfect. Awesome. Topoisomerase 1 inhibitor. Which drug toxicity and antidote are correctly matched here? Irinotecan, myelosuppression, and atropine? Yes, no. Awesome. Okay, I'm hearing doxorubicin, cardiotoxicity, and dexrazoxane. Yep, so dexrazoxane is kind of your antidote or treatment for cardiotoxicity and extravasation with anthracyclines. Atropine is going to be a prevention or treatment for the cholinergic diarrhea that we see with irinotecan. Would have no use for atropine really with anthracycline. Okay. And then, so what's the mechanism of dexrazoxane in treating an extravasation? Yeah, yep. So binds to topoisomerase 2 beta, preventing the anthracycline from then inhibiting that enzyme. Right. And then which supportive, sorry.
That reaction of binding with topoisomerase 2, is it reversible, is it competitive, or all happens in that?
Yeah. Yeah, it's competitive, so it's reversible. That's why the repeated doses are important and necessary for the dexrazoxane. And so we would expect it's going to be, cleared at some point as well, which is why we give 3 days of dexrazoxane for an extravasation, and with prevention of cardiotoxicity, you give dexrazoxane with every dose of the anthracycline.
It binds and prevents the enzyme. But we see binding to the enzyme, not also like stopping the enzyme from activity. Like the enzyme get inhibited.
I'm sorry, I can barely hear.
So it binds and inhibits, it prevents the water from binding to the enzyme. But it's also binding to the enzyme. So the enzyme is also inhibited by.
Yeah, so it's binding in a slightly different place that doesn't inhibit the enzyme activity. And sorry, I should go back to the microphone. It's binding to a slightly different place. So it's not inhibiting the activity the same way as the anthracycline does. So it's not exhibiting that same toxic effect, but it's preventing the anthracycline from binding by changing the enzyme receptors. And I will also admit that this is kind of a presumed mechanism for how this is. Like, this is an action that we know that the dexrazoxane has. And so that's the presumed mechanism. But there is still, I think there's probably a bit of a lack of understanding what is truly happening to prevent. But we've seen that it does have that activity, and it is preventing the cardiotoxicity. There's a lot of data supporting that the use for prevention of cardiotoxicity and for prevention or for treatment of extravasation. So this is kind of the mechanism that's been identified that's presumed to be the primary driver of that. But it's possible that there's another component that is not as well understood too. But that's a good question. It's not inhibiting quite the same way the activity of the enzyme. So it's not causing that same toxicity. Yeah. Okay, so then which supportive care agent would be most appropriate for a patient experiencing diarrhea 3 days after receiving irinotecan? Loperamide, perfect. If this was 3 hours after receiving irinotecan, atropine, perfect. Okay, and then risk of cardiotoxicity increases significantly when administered beyond a cumulative lifetime doxorubicin dose of 400. Awesome.
What?
Okay. I think that this is a good spot to take a break. 10 minutes, so we'll start back up at 12:21. Oh.
Okay. 400. Bueno, más de 400. Okay. Sí, a ver.
Fine, it's being recorded, I think, too, so. Should be able to- so let me know, my email's on here tomorrow. It is something that you missed at the beginning.
Well,
thank you for coming. Same day.
She said something to me, and I just said, "¿Qué pasó?" And I said, and I walked away. I'm like, "They're not saying anymore." They know I don't know. At work, I said it to them, they come up like, "¿Qué pasó?"
Okay, if everyone can make their way back to their seats, we'll pick back up. I also feel like I heard that you guys have spring break next week, so we'll try to wrap things up. Get you on your merry way. Okay, so we're gonna wrap up now with antimicrotubule agents. So this group of medications includes vinca alkaloids, taxanes, and then a couple other agents that are related to taxanes, epitheliones, and haloconins. All right, so we've got two main groups here, the vinca alkaloids and the taxanes, and then the other couple agents that we'll talk about are pretty similarly or closely related to taxanes. So vinca alkaloids are inhibiting formation of microtubules that then result in cell arrest in metaphase and then cell death. The taxanes are stabilizing microtubules and then resulting in mitotic arrest at G2 and mitotic transition, and then cell death as a result of that. So working in very different ways, but impacting the microtubules, either stopping formation or stabilizing those microtubules to a point that the stabilization is inappropriate and results in them not being functional. Okay, so we'll start with the vinca alkaloids. So vinca alkaloids were discovered in like the late 50s, kind of accidentally, as a lot of these drugs are. They're naturally occurring components of vincristine and vinblastine, were isolated from the leaves of the periwinkle plant. There are three agents in this class, vinblastine, vincristine, and then vinorelbine. Their uses again are somewhat broad. We've got some heme malignancies here, some solid tumors as well. And then some of the example regimens listed for you at the bottom of the slide again, largely being used in combinations again. There are some monotherapy uses for vinorelbine, but again, largely these are going to be a component of a bigger regimen for treatment. All of these agents have hepatic dose adjustments based on bilirubin, and they're not recommended in severe hepatic impairment. They also have CYP3A4 interactions, so all of these are substrates of CYP3A4. So something to be mindful of. And these are also vesicants, so that means they have a higher extravasation risk as well, similar to what we discussed with anthracyclines. The extravasation risk and the kind of severity of extravasation with anthracyclines is higher than with the vinca alkaloids, but something to be mindful of again here with these agents. Despite those similarities and the closeness of like their chemical structure, there are some pretty big differences between these agents and what toxicities they have. So vinblastine and vinorelbine have a really high neutropenia risk, whereas vincristine is much less so. However, vincristine has its own unique toxicities that can also be quite severe. So the major toxicities with vincristine are neurotoxicities, including neuropathy, both peripheral and autonomic. So autonomic neuropathy is going to result in or lead to severe constipation. So for patients receiving vincristine, we want to be really proactive about a bowel regimen for those patients to prevent the development of constipation. It can be very, very severe and lead to like obstruction in patients receiving vincristine. So not something to kind of sleep on or wait around for. Some other things to be mindful of with vinca alkaloids is safe administration. So the inadvertent intrathecal administration of vinca alkaloids can lead to painful ascending paralysis, and essentially the destruction of the central nervous system radiating from the injection site. Most of the time, this results in fatality. Vincristine is particularly problematic for kind of these accidental intrathecal administrations, and is associated with the most instances of this being reported because it's often being given in conjunction with medications that are administered intrathecally. So in some of the heme malignancies where we're using vincristine as a part of the regimen, we are giving like intrathecal methotrexate or cytarabine for patients who have CNS disease. And vincristine the doses are small, the amount is small. And so if it's drawn up into a syringe and there's another syringe with a different chemotherapy agent that is intended to be given intrathecally, there's a lot of risk for inappropriate administration. To prevent this, these vinca alkaloids should always be prepared and dispensed in like an IV bag, never in a syringe. It would be a lot harder to accidentally administer a medication from an IV bag intrathecally than a syringe. So this is a big kind of institutional policy pretty much everywhere to prevent administration of vinca alkaloids inappropriately intrathecally. From an extravasation standpoint, similar to the anthracyclines, giving via central line is preferred. So that is a good way to minimize and prevent extravasation. You can also administer these to gravity. So kind of like letting it hang and not via an infusion pump to avoid extravasation injury as well. Then the other major group of chemotherapeutics in the antimicrotubule group is taxanes. So these agents are derived from a species of yew trees within the genus Taxus. So Taxus taxane, super creative there. There are 3 agents within the taxane family here. So paclitaxel, docetaxel, and cabazitaxel. Again, the names here are kind of helpful to group this into the taxane group. Another pretty wide variety of use for these agents. Taxanes are used more exclusively in solid tumors than hematologic malignancies. So a lot of breast cancer, lung cancer, prostate cancer has a lot of taxane use as well. You can see some of those regimens on the bottom of this slide. Cabazitaxel is another agent that is actually only approved for use in prostate cancer. So this is another one that I see in my patient population. From a toxicity perspective for taxanes, across the board, we can see hypersensitivity reactions to taxanes, which we'll talk more about. And we can also see pretty severe myelosuppression or neutropenia with these agents as well. So later on in the course, you'll have supportive care lectures that talk about like growth factors for support in these regimens that have really high risks of neutropenia or myelosuppression. So these would be agents that we would be considering some extra supportive care to support count recovery in these regimens. Nausea and vomiting is pretty common with these medications. We can see neuropathy, weakness, muscle weakness. Paclitaxel can cause bradycardia sometimes, and we can see fluid retention with docetaxel. So a couple differences there. The neuropathy tends to be worse in patients receiving paclitaxel than docetaxel or cabazitaxel, but there is a risk with all of the agents, so something to be monitoring for and assessing for prior to like each cycle being administered. I know in my patient population, for prostate cancer, we're usually targeting 6 cycles of docetaxel. And it's not terribly uncommon for us to stop at 5 because people start to develop pretty significant neuropathy that's not always going to be reversible. So that can be a dose limiting toxicity for these agents. And then hypersensitivity reactions. So I mentioned these are very common with taxanes. These molecules, so these, the drug component of the taxanes are not intrinsically soluble in water. So they have to be combined and given with a delivery vehicle. Paclitaxel, it contains cremaphore, which a lot of people react to and have hypersensitivity reactions to. Docetaxel and cabazitaxel contain polysorbate 80, which is another big problem for reactions in medications. So all of these agents carry a risk for hypersensitivity reactions, and say a reaction to docetaxel might kind of clue you in that there's a very good chance they would have a reaction to like cabazitaxel, understanding that it's that same component in the solution that's probably causing the hypersensitivity reaction for a vast majority of these patients. So not generally a reaction to the drug itself, but that delivery vehicle in the solution. The risk of reactions is generally thought to be higher with cremaphore. So paclitaxel has the highest risk of reactions within the taxane group, but they definitely all carry a risk. These typically are occurring pretty quickly in the infusion. So within the first 10 minutes of starting treatment, if you stop treatment, the reaction resolves. It can be like flushing, it could be a rash, bronchospasm, or trouble breathing, hypotension, itching, pain, and like the chest. So some patients feel like they have like just tightness in their chest. And then a lot of patients also describe back pain as a component of the hypersensitivity reaction as well. So it can look a little bit different for different patients, but typically pretty quick with the start of the infusion. Because of this high risk for reactions with the taxanes, we routinely pre-medicate patients before giving these medications. So all patients should be pre-medicated with a corticosteroid, a histamine agonist like diphenhydramine, or histamine 2 receptor agonist like famotidine. So our typical go-to for these these therapies are dexamethasone, diphenhydramine, and famotidine, all given 30 minutes before the infusion. If reactions are super severe and someone doesn't have great other alternative treatment options, there are desensitization protocols to try to slowly expose people to the therapy to get them through it. I will say that at that point, again, allergy consult and lots of other assessments are involved as well, and is not always our go-to. If we can pre-medicate and get through it, great. If not, then maybe we're thinking about other potential treatment options for people if they're super severe reactions. All right, ixabepilone is another antimicrotubule in the epithelium class, which is very closely related to taxanes. It's a macrolide compound that was isolated from the Mycobacterium sporangium psilosum. It binds to beta tubulin in the microtubules, leading to suppression of microtubule dynamics. It's more potent and less susceptible to some of the resistance mechanisms that we see with the taxanes and the vinca alkaloids. Thus, it kind of shows activity in patients who have taxane resistant cells. And that's really its main place in therapy, is for treatment of patients with breast cancer that is refractory to anthracyclines and taxanes. So, trying to bypass some of those resistance mechanisms that we can see develop. Because of that, this is a pretty rarely used agent, so it has a fairly specific place that it's used. And this one and the next agent we're going to talk about pretty much the same use here for those refractory breast cancer cases. Toxicities are pretty similar to taxanes. So they're thinking about myelosuppression, weakness, alopecia, mucositis, diarrhea. We do have some neuropathy risk here as well. And then again, we're seeing PPP4 in this solution. So also have that risk of hypersensitivity reactions and a need for pre-medication with exabepiline as well. Exabepiline should not be used in patients with severe hepatic dysfunction. There is a black box warning for use in severe hepatic dysfunction due to an increased risk of toxicity and neutropenia-related death in patients with severe hepatic dysfunction. And then our last antimicrotubule agent is eribulin, which is a synthetic analog of halocondrin B, which is a natural macrolide that is derived from the marine sponge. So eribulin inhibits mitotic spindle formation via suppression of microtubule polymerization. So similar to exabepiline, I mentioned this is way more potent microtubule inhibitor than the taxanes. So its first and main use is again in breast cancer that is refractory to taxanes. Eribulin does have some other indications for use in some sarcomas, but really first used in that kind of refractory or resistant breast cancer setting. Main toxicities here include myelosuppression, peripheral neuropathy, alopecia, and then also does carry a risk of QT prolongation. So that's extra monitoring piece for eribulin that we haven't really talked about with some of the other microtubule inhibitors is monitoring EKG and QT. Okay, and then I have some questions to walk us through for the antimicrotubules as well. So why should vinca alkaloids never be given via intrathecal route?
Never what? Never does.
Can cause paralysis, basically destruction of the CNS central nervous system. So can be fatal. Most often is fatal. So big no, big safety problem. Okay, what's the role of PPP4 in taxane solutions other than causing hypersensitivity reactions? Yep. Yeah, so it's a delivery vehicle because these are not soluble without the addition of a delivery vehicle. So that's where PPP4 and polysorbate 80 come into play with the taxanes. So select the appropriate pre-med regimen for a patient receiving cabazitaxel. So what would you want to give? Yep, perfect. So corticosteroid and then antihistamines, H1 and H2. So diphenhydramine and famotidine. And which toxicity is common with both paclitaxel and vincristine? Yeah, so neutropenia is common with some of the other vinca alkaloids. It's less common with vincristine, but we definitely see neutropenia with paclitaxel. And I heard peripheral neuropathy. So that's what I was looking for here. So peripheral neuropathy, neuropathy in general is very common with vincristine. So that's our big toxicity with vincristine. And then we see a lot of peripheral neuropathy with the taxanes as well. Paclitaxel being kind of on the high end of peripheral neuropathy within that taxane class. Perfect. And then what is an important supportive care consideration for patients receiving vincristine? Yeah. Yep. A bowel regimen for constipation. Perfect. Yeah. So that's where we have that autonomic neuropathy, causing severe constipation with vincristine. So important to be very proactive with a bowel regimen for those patients. All right, so big picture takeaways, topoisomerase inhibitors and antimicrotubule agents are very widely used across solid tumors, hematologic malignancies. There are a few that have, kind of their niches, but overall, we're seeing these agents pretty broadly used in chemotherapy regimens in combination with other agents. Some of the notable toxicities for these agents are severe diarrhea with irinotecan, so being acute and chronic and kind of delayed diarrhea with the irinotecan. That acute diarrhea, we're using atropine to manage and prevent due to the cholinergic reaction. And your delayed diarrhea management with loperamide is helpful and important. For the anthracyclines, we have that risk of cardiotoxicity with our high cumulative doses, and dexrazoxane can be preventative for that and help decrease the risk of cardiotoxicity. Once you get to that lifetime cumulative dose of 400 or more, the risk is really increasing pretty significantly. So important to be mindful of cumulative exposure to anthracyclines. Vincristine, as we just talked about, peripheral neuropathy and severe constipation are kind of our big toxicities to be watching for and mindful of, proactive about with those. And then with the taxanes, we have pretty high incidence of hypersensitivity reactions due to the polysorbate 80 and the cremophore in those solutions. So pre-medication is really important to getting those therapies to patients without issues. And if you have any questions right now, feel free to ask them. Otherwise, feel free to reach out via email. I'm happy to answer questions or talk through things more. And I can hang around for a little bit too if anybody has questions. Otherwise, I think I'm back in like 4 weeks for your prostate cancer lecture. So I will see you again in like a month.